This video is presented by TRACS WA, Training Centre in Subacute Care.
Motivational interviewing, or MI, is concerned with behaviour change in an interpersonal context. So it's of great interest for people working in health, as we're often working with people's ambivalence around making healthy behaviour changes. So as warm, caring health professionals, we can kind of see where we would like our clients to go. But often we're met with a lot of resistance from them about where we think they should go. And, sometimes this is kind of reframed as saying that they're not motivated or they're in denial of their problem. When in fact, maybe it might be that the way that we're interacting with our client or our patient is part of, the ambivalence there. So there's an interesting quote that says that it's not that our patients are not motivated, it's just that they're motivated to get away from us. So motivational interviewing teaches us methods to kind of roll with this very normal state of ambivalence that exists within all humans. So it doesn't really matter if you're a dietitian working with a diabetic patient to change their eating habits, or maybe you're an OT working with a stroke patient to reduce their risk factors of stroke. If you work in health, motivational interviewing has something to inform your practice. Motivational interviewing isn't about getting your patients to do what you want them to do. And it's not about motivating patients to do an exercise routine or do their homework or eat healthy. It's really about resolving ambivalence. So motivational interviewing puts the patient in the expert role, and it says, let's work together, let's put our heads together to try to understand what's going on and, figure out where you want to go. The spirit of MI is as important as the methods of MI. And Carl Rogers, whose therapy informs the practice of MI, remarked that in his early years, with working with patients, he was thinking, how can I treat or cure or change this person? But on reflection, he was thinking, how can I provide a therapeutic relationship with this person to enhance their own personal growth? This reflection of Carl Rogers neatly summarises what Miller and Rolnick, the founders of MI, believe is essential to its delivery. It's creating this sort of space, this way of being with someone, so that we can work through the ambivalence. That's a very normal part of any change process. So the spirit of MI has three important characteristics. Collaboration, so putting our heads together, therapist and patient, and working about how we can work this out. The second part is autonomy. So the patient is seen as the driver of their own change. So our job is to recognise that they're the expert in them and to facilitate a change process, whereas they're the driver. And the third part is evocation. Motivational interviewing is a very evocative therapy in the sense that we're asking people to really reflect and think about who they are and who they want to be. And in that kind of gap between those who they are and who they want to be, sort of facilitate a change process that might move them towards a healthier life. Research has shown that people who are experienced MI have conversations with patients that elicit more change talk and less resistance talk. And what the research shows is that less resistance talk, more change talk leads to better outcomes. I think it's a really inconvenient truth of being a health practitioner that our patients' lack of success in making healthy changes in some ways might be attributable to our interpersonal style with them. The elements of MI address what the clinician says to the patient and how they say it. Principles like expressing empathy, developing discrepancy, rolling with resistance, facilitating change, and supporting self-efficacy are separate and interrelated concepts that people need to be aware of when they're doing this kind of work. All of these elements together are utilised to evoke a patient's movement in their chosen direction. And it's in what the words of Bill Miller is, "I believe what I say when I hear myself say it." With the element of expressing empathy, the clinician elicits from the patient in a non-directive and supportive way their concerns and feelings about their ambivalence and the changes they want to make. So in motivational interviewing, there are what's called OARs. And OARs is an acronym for open questions, affirmations, reflective listening and summaries. So weaving together these OARs is how the skilled motivational interviewer keeps a conversation flowing towards change talk and resolving ambivalence. I'm sure many of you are familiar with open questions, and these are the backbone of motivational interviewing. What's brought you in here today? Do you mind if I ask you a little bit more about that? We always want to keep the conversation moving. Try to avoid yes-no questions, although sometimes they're useful to get some clarification. I think the other thing about the empathy part of motivational interviewing is that we want the client to do most of the speaking. So if you notice in your session that the client's doing about 50% or more of the talking, then you've probably got the balance right. If you're doing more of the talking than them, I don't know that you're in the territory of expressing empathy. And affirmations are always given as a statement, like most of motivational interviewing reflections. So for example, when someone comes in and shares something deeply personal, you might say, gee, that was a really big step in sharing that with me. So affirmations are this way of keeping the conversation moving, but also developing that deep sense of connection, which is the spirit of motivational interviewing. Reflective listening is one of the most important and probably challenging skills of motivational interviewing. What it involves is taking a guess about what a client might be feeling, trying to evoke from them what's sort of sitting beneath the surface. The best analogy I can give, it's a little bit like looking beneath the iceberg and reflecting that back to the patient in terms of a statement, never a question. So this is a skill that takes some practice to develop, but if you can get very good at it, it makes the process of motivational interviewing a lot more seamless. People often comment that to reflectively sit and listen to someone, it's probably going to blow out their clinic timeline. But the research says that if you can do it for about 3 or 4 minutes, generally speaking, that's all you need. We use summaries to acknowledge and empathise with what's been said, and then also kind of solidify some of the change talk language before we then move forward about making a plan. The goal of motivational interviewing isn't just to reflectively listen to patients. And in fact, it is a directive therapy in the sense that we're aiming to move our clients towards healthy behaviour change. So how we do that is by developing discrepancy. Now, if we had a drug-addicted person who had a very serious and life-threatening drug habit, we wouldn't sit across from them and merely reflect back to them how difficult or painful their situation is. We would be trying to kind of get in there and help the person to understand their current state and how that differs from perhaps their ideal state. Finding out what really matters to people. Questions like, what matters to you? What is it that you want your life to be about? How does your use of drugs and alcohol get in the way of you being the person that you want to be? These are all really good questions that kind of drive a bit of a wedge between the person's current state and their idealised state. So importance rulers is where we start at 0, where 0 is not really important, up to 10, and we ask people to put themselves on this scale between where 0 not being important, 10 being really important, what change they'd be willing to make. You get a number, and then you can kind of dance around this ruler. I think what I've noticed is that people often stop at the first number they get. But if you really, really want to develop discrepancy, if someone gives you a 5, ask them what a 6 would look like. Ask them what an 8 would look like. Find out what a 3 is. And all of a sudden you've got some information of difference. And I think that most of you would be aware of cost-benefits analysis when it comes to change. So we'll ask people what's the good things about staying the same, and then we'll contrast that with what are the not so good things about staying as you are. And then we'll flip it and we'll ask them about the good things about changing, and then we'll ask them about the not so good things about changing. And in those 4 quadrants we develop discrepancy, and discrepancy is really designed to then get the person to think about if they want to stay or move towards a healthier state. The object that we want to put in motion when we talk about rolling with resistance is the client's perspective. And we want to keep rolling it and moving it and shifting it so that they can get a different perspective on the struggle that they're having. This is to avoid what commonly happens in health settings, is where therapist and patient butt heads with each other because both bring different agendas to the conversation. This is typically known as the yeah but effect, and I'm sure that many of you will have had the experience of sitting with someone and getting this kind of yeah but response to many of the very helpful and thoughtful suggestions that you're offering the patient. So this is a sign of resistance. So be aware of that. What we want to do in motivational interviewing is we don't want to hit that front on. So how do we roll with resistance? Ask permission. Permission is one of the key ways to get the client alongside you and to decrease these feelings of resistance. Commonly, we can put a menu of options in front of someone and they choose which topics they would like to talk about and which ones they won't. And most importantly, avoid arguing in support of change. The more that we argue in support of change, the less likely we are to see change. And just look for subtle changes in your client's behaviour. If they're denying, shifting focus, looking disengaged, these are all signs that resistance is very strong and that you, the clinician, need to change your stance. Supporting self-efficacy is another important element in motivational interviewing. And in many ways, it could be seen to be the most important. If a skilled motivational interviewer engages and empathetically with someone, develops discrepancy, rolls with resistance, but the person feels hopeless about making change, then change won't occur and all our efforts will have been in vain. So it's very important that we turn our attention to drawing out the intrinsic motivation within people to help them feel confident about making moves towards change. With supporting self-efficacy, we use confidence rulers. So we ask people the same question on a scale of 0 to 10, 0 being not very confident, 10 being very confident. How confident are you about making this move? And as before, we kind of dance around on that ruler. If they're a 5, we ask them what a 7 would look like. If they're a 3, what would they need to do to get to a 5? And then we can, again, work with their ambivalence. Other things we can do is ask questions. What needs to happen? before you can make this change? What would it feel like if you were able to make this change? Strengthening commitment to change is another important element in motivational interviewing. So once a person has reached the point of being ready for change, switch the conversation towards planning for change. And we do that by asking them some key questions. When are you going to do it? How are you going to do it? Is there anything that might get in the way of you doing? Goal setting is a really important part of strengthening commitment for change. Get the person to write down those SMART goals, those specific, measurable, achievable, realistic, time-limited goals. Get them to put it down on a paper, because it's sort of like a commitment when you put something down on paper. When they're doing that, also plan for roadblocks. What will you do if the plan doesn't work out? What's your plan then? And if you can do that, I think you arm the person with the best chance of committing to and following through with the change that they want to make.
Tracks WA would like to thank the staff of Solutions Health Psychology for their involvement in this project. This project received funding from the Australian Government.